Hello, I am Jennifer Carroll. I am a harm reductionist and medical anthropologist based in the United States. It's my pleasure to be speaking to you today about the opioid overdose epidemic in the United States, where we are now, how we got here, and what we need to be doing about it from this point forwards. If you have ever seen anyone give any history or explanation or any kind of presentation on opioid overdose in the United States, chances are good that you have seen this graph. This is typically how our public health authorities and experts talk about the opioid overdose epidemic in the United States as something that has happened over time in the last 2 decades in 3 distinct waves. The first of those being death from prescription opioid overdose, followed by a wave of heroin-associated overdose fatalities beginning in 2010, and then starting in 2013 to 2014, the takeover of synthetic opioids like fentanyl and fentanyl analogs in our illicit drug market, that now becoming the leading cause of opioid overdose fatality in the United States. So this chart tells us a lot. It paints a pretty stark picture about how rapidly the drug market has changed. But I do also believe that this chart leaves quite a bit out. So specifically in the first wave, when prescription opioids were becoming a larger and larger public health concern, we know that at this time, Colombian heroin in the United States was occupying a larger and larger market share in the illicit drug supply. Prescribing of oxycodone, for example, increased by 600% over an 8-year period. But we do know that even in this early stage of the opioid overdose epidemic, polyopioid use was common, and many people used both heroin and prescription opioids interchangeably or at the same time. So this hasn't always been a purely prescription opioid driven problem. The second wave, when heroin-associated deaths began outpacing those of prescription opioid-related deaths, I want to draw your attention to this point in the chart. There's an angle, right? There's actually a corner there where you can see that the rate of heroin-involved deaths really started to climb. And that should tell you that something happened in 2010 that changed the risk environment that people who use drugs were living in the United States. In 2010, our Food and Drug Administration approved a reformulation of Oxycontin, a long-acting opioid analgesic that had, for a long time, I think represented a large market share of the types of prescription analgesics that were being diverted and misused or used non-medically. What this ultimately did was take a substance that was widely available and was safer than heroin insofar as it was regulated, it met safety standards, the dosages were very clear, and took it off of that market. And we saw a huge shift over to heroin. We know at this time also that heroin is purer, it's cheaper, and because of the glut of Colombian supply, much more prevalent. At this point, we also know that overdose begins to rise, hepatitis C infections begin to rise, and multiple studies have associated that specific change with this regulatory action specifically. Then in 2014, with the rise of synthetic opioids in the illicit drug supply in the United States, we had this wrongly assumed but very widespread and very well believed idea that was perpetuated, especially by many law enforcement organizations, but not only, that fentanyl was appearing in our drug supply because of user demand. The story was that people who use drugs were seeking this ultimate high. We now know that that's not true. And in fact, unpredictability of the drug supply as fentanyl was coming into it became one of the primary drivers of overdose risk. This is now very well established as a supply side phenomenon, so something that was happening way up the chain, and people who used drugs were very much being caught off guard with an unpredictable supply. So this also meant that home strategies or folk strategies for avoiding fentanyl or staying safe while using fentanyl became much more prevalent. People started trying to communicate with each other, relying on trusted suppliers, because it really, really became unpredictable out there, and it became very scary. Now, our public health entities have responded to this, I think, very well. This is a document that was put out in 2018 by the United States Centers for Disease Control and Prevention. Full disclosure, I'm the first author of this document, but this was a document that was requested by our CDC. It was vetted by the CDC. It was approved and published and branded by our CDC. And this is a tool that was meant to be available for communities in this really easy to read format, very, very simple sorts of instructions instructions, how-tos, summaries of research, and these were all evidence-based strategies. Things like targeted naloxone distribution, syringe service programs, medications for opioid use disorder like buprenorphine and methadone, removing prior authorizations from health insurance coverage of those medications, providing all of those services to people who are in jail or incarcerated. And we had for a while a very data-driven approach, or at least our public health agencies were promoting a very data-driven approach to opioid overdose in the United States. Well, here's where we are today. Across the country, we've had a nearly 30% increase in overdose fatality just in the last year. 30%. We're losing so many people. So what's holding us back? What's not working? Why is our evidence-based approach to opioid overdose failing to stem this cascade of overdose fatality across our communities? I think there's a few reasons. The first one is that we are still not listening to people who use drugs. I think it's important to note that our most effective overdose prevention strategies, syringe exchange, naloxone distribution, drug checking, these are all innovations that have been brought to us by people who use drugs. And even though some of that insight appears in what our public health agencies are doing, there's plenty of things that people who use drugs are telling us now that we're not listening to. For example, there has been really well-organized advocacy around methadone in the United States, a drug that is very much kept under lock and key and is only dispensed through a very carceral, very punitive approach that's a huge barrier to care for most people. So while we are debating whether or not to criminalize new fentanyl analogs or allow fentanyl test strips to be purchased with federal funds, we're failing to address very fundamental models of access to care. Second, in the United States, we fail to recognize how our racial politics skews our understanding of drug use as a social problem. Our criminalized war on drugs was begun in the Nixon administration in the 1960s, specifically as a tool of anti-Black racism, because the idea of who uses drugs and why they use drugs is so deeply tied up with white supremacy and anti-Black racism. Our stories about whether or not people who use drugs are good people or bad people, deserving people or undeserving people, is deeply caught up in our ideas about race. What we see here is a graph of office visits for buprenorphine, another medication for opioid use disorder that is much less regulated and much more easy to access than methadone. Even though we know that opioid overdose death among Black communities is very quickly catching up to that seen in white communities, we cannot get these medications into Black populations. There is no access. And part of this comes down to whether or not patients are shuttled into the more independent system of care for buprenorphine from your primary care provider, or whether they are shuttled into more punitive and carceral solutions like methadone or like prison, most of which do not offer methadone or buprenorphine at all. And finally, we as a society are unable to make this leap from keeping people safe to providing safe supply. If you think back to the first slide where there was that sharp increase in heroin-related overdose deaths after the reformulation of Oxycontin in 2010, that is attributable to people switching from Oxycontin to heroin or from prescription analgesics to heroin, but it's also attributable to the fact that heroin is much more dangerous than a prescription opioid, even if that prescription opioid is being used in a fundamentally unsafe way. We're able to muster political and social support for certain harm reduction activities like syringe access, like naloxone access, and in fact, even support for drug checking is slowly growing in the United States. At the same time, providing someone who uses drugs with a safe supply, making sure that the drugs they're going to use aren't going to kill them in the first place, is something that is still unthinkable. We need to be able to make that leap between just doing some stuff to keep people safe and really making sure that people have safe stuff when they're going to use, because they are going to use. I want to thank you very much for your time and attention, and I want to invite you to contact me with any questions that you may have.